question which I want to pose to Dr. Gusti is that when you do supine PCNL, which is the calyx of choice which you would like to take? Is it the anterior calyx or it's a posterior calyx? Because in prone position, posterior calyx is of a choice because we can go from patient is in prone position and from prone to anterior we can go. So here, which is your choice of calyx?
Well, this is a nice question. Honestly, my answer would be my calyx is the one that allows me to do the best job. So if it is the posterior one, I will go through the posterior one. If it is the anterior one, I will go through the anterior one. But believe me, I'm quite sure that we have to rewrite a little bit the anatomy of the kidney, because if the anatomy of the kidney that we demonstrated for prone PCNL was completely right, I think that supine PCNL wouldn't be possible. So I think that the posterior calyx, posterior lower calyx, is not so posterior because most of the time I can reach it very, very easily. But for sure, if sometimes you need to go through the anterior calyx, it's much easier in supine. Honestly, you know, in the past, the reason why not to go through the anterior calyx was that because it is supposed to be anterior to the avascular line. But honestly, in my experience, also this has to be really right. I have never experienced a major bleeding because I punctured the anterior lower calyx. What is your experience?
Yes, I think you're right that we also have experienced the same thing. That sometimes we discuss a lot about the posterior anterior, but in supine, quite often, whichever calyx is posterior, we tend to clear the stone without much problem. So I think you're right in that sense that we need to really relook the whole thing once again. But let us come to this case that this is a 11 years old girl and this is a plain X-ray KUB. This is the IVP, a normal creatinine, and this was the stone configuration. You can see here the pelvis which is there, and you see these stones which are there scattered everywhere. Now, Dr. Gusti, is it a case for supine PCNL?
Consider that for me, 99.9% of PCNL are supine. So for sure it is, but my final answer should be based on a CT scan, axial images on CT scan. But taking a look at this, it seems a very nice case for supine and especially for combined. Because
yes, so combined, yes. But now the question pertaining to this I want to pose to you is that when you are doing the supine PCNL, do you have the ability and the space basically to make multiple punctures, different punctures in the different calyces? Because in supine, the problem is that there's a space crunch. And how do you, especially if there are crowded calyces and if there are different calyces, then how do you manage to have, suppose this patient requires multiple punctures, flexible laparoscopy also doesn't go with the awkward angle, then how do you manage that?
You know, Dr. Sabnis, I think that it's a matter of mentality. It's a matter that we have to free our mind. It's a matter of mindset. It's not true that there is so many difficulties in targeting different calyces. The procedure is the same, only the angle is different, but usually, as I show you in my presentation, sometimes I perform only 5 axes, but the rationale is the same of prone. And only sometimes, if you have to approach the upper calyx, but only sometimes you have to be more posterior with your needle. But usually, it's not a big deal to do multiple punctures. Believe me, procedure is the same, and I would never say when a multiple access PCNL is supposed to be, I will go for prone. Not in my experience.
Okay. So I think that's a very important message which you are passing across. Well, this patient was before the era of flexible retroscopy, and that time we had done with the multiple punctures PCNL spread over the multiple switches, multiple track PCNL, but ultimately we could achieve the complete clearance on the left side. And then subsequently we did IVP, which showed that yes, the function was properly maintained. But before we go to the this, now this is the very important case, and I think all those in the audience who are watching, they are quite keen to know what is your special tips and tricks to manage this case, which has got a vertical stone, which is 33 millimeter in size, and it is in the upper calyx. And if you see the reconstructed image, a 3D image of a CT scan, this is the stone which is vertical. These are the calyces which are completely undilated, almost touching the 12th rib, and the stone is like this. The flexible laparoscopy, even if you pass this angle, you may not be able to go. So in supine PCNL, what is your tip and trick?
So
Is it a
please
case
go
for
back.
supine PCNL?
Yes, go back, please. Okay. So at the end of the day, this is, of course, not an easy supine, because the trajectory should be, the axis should be more posterior, also because we have liver and then we have also the rib. So my strategy would be to go supine with the major inclination of the patient, but for sure also to do a paraspinal puncture in prone can be an alternative. This is an important point. I don't want to tell you you have to do supine all the cases. You do supine only when you are sure that you can do a good job. For example, in this case, you can start to approach the calyx in supine, but if you realize that you are not able, it is not a shame for me in my OR to change my mind on the way and say, guys, this is not the case for supine, let's flip the patient. But I think that there is maybe there is also a little window above the rib. And in this case, of course, ultrasound is very, very important because, of course, you have to take care also the liver.
Right. Now, Aditya, I want to ask you, in your practice, when you see such awkward cases which are probably different for supine PCNL, how do you make the selection of the case? Do you consider that every case is for supine, or you have the certain selection criteria for supine and prone? Aditya, can you tell us that?
Yes. Sir, for me,
Listen,
for me, technically, any stone for which PCNL is needed, supine PCNL is feasible. And if we talk about the similar this stone, can I share one small video of puncture? I had done a similar kind of looking stone, if you allow me.
Just quickly, if you can share,
Sure.
because we don't have much time. But quickly, if you want to share, yes, it will be great.
So, is it visible now? Okay.
Yes.
Now we will demonstrate the technique of superior calyceal puncture in proximal position. Anatomically, kidneys are treated.
I'll just skip this part. So
yeah, just skip and then come to the main part.
Yeah, I'll just come. So this is the superior calyceal stone.
For superior calyx will be.
So I'll just pause it here. The point is we are discussing is where do we decide to make a puncture? As we move from inferior to superior calyx, anatomically kidney upper pole is more medial and posterior. So the superior calyceal puncture has to be supracostal and it has to be more medial. So this is possible when we have, like Dr. Guido also said, he keeps patient at more inclination.
Lateral and anterior and puncture for superior inferior.
So now I'll show the puncture.
Yeah, show the puncture and then we'll take the comments from Gusti.
Yes, sir. So we have done puncture. This is the 12th rib. So I've gone between 11th and 12th rib. I have marked for inferior calyx, mid calyx, and upper calyx. How would I do my puncture? And I've gone supra 12th and I have started
much medial to the posterior axillary line, and 0 degree, once desired calyx is reached, we rotate the C-arm in the same way in craniocaudal direction, needle moving in the same direction as the X-ray tube. Therefore, it is anterior and the direction is readjusted to reach the calyx once again. After reaching the calyx, rotating C-arm in craniocaudal direction, we can see there is not much relative movement between needle and the calyx. After
so this is a successful puncture we have done.
Yeah, correct. So I think you have highlighted and demonstrated how the puncture can be done. Now I want to ask Dr. Gusti and then ask subsequently Dr. Mahesh Desai. First, I want to ask Dr. Gusti that you saw the puncture in the upper calyx and you also demonstrated in your talk that upper calyx can be easily punctured. It is not a big problem for supine PCNL. I want to know when you make the puncture of from the lateral side to the in supine position, don't you feel there is a little bit of a torque which you feel when you want to go from upper calyx to pelvis or the lower calyx? Is there any torque on the kidney which can lead to a little bit of a more bleeding?
This can be a good point. For sure, in supine, the angle is more favorable if you access the kidney from the lower calyx. So torque is always something to be aware of. But because when compared to prone, you are right. The puncture of the upper calyx especially is much more lateral. So
Yes.
the infundibulum of the upper calyx sometimes is not in direct line. But that's why as soon as I have the feeling that I'm giving too much torque, flexible scope is on my table, and of course I will take it and abandon the rigid.
Yes. Okay. I think that's also very important message, Dr. Desai sir. You want to make some comments?
Yes. Can you hear me?
Yes.
Yeah. Yes. What I had planned in this case, we have put a DJ stent, and I'm we're going to do a ureteroscopy. We can clear the infundibulum and the upper calyx, but this side, the lateral calyx is at an angle. You cannot do it with the ureteroscope. And in the supine position, we are planning to do a microperk, where you would be able to puncture that small calyx. You can see that on ultrasound very well, and you would be able to puncture. Now, when you puncture and you see also. So ultrasound will give you the direction plus you see, and that small stone will fragment with laser, which will come out into the calyxal neck and the infundibulum, and then clear the stone. So that is the planning. That flexible ureteroscope with a microperk. The problem with supine position in upper calyx, if you dilate, you will have a problem. If you don't dilate, you would not have a problem. I mean, you would be able to do the microperk, and then with a flexible ureteroscopy, with combination in supine position, you can do it.
Yeah, Dr. Gusti. Now look at this X-ray. Now the upper calyx shown on the left side, and upper calyx, middle calyx, lower calyx stone, and a multiple stones in the ureter. Let us focus on the right side. Now you see the whole kidney, the whole calyx is actually above the 12th rib, and almost part of it going into the above the 11th rib. Now if you have to focus on the right side, how would you make a puncture if you have to really do supine PCNL, and how would you take care of liver? Because in upper calyx, such a high, in prone there is a problem of pleura, but in the supine there's a problem of liver. So how do you take care of that? And what is your message?
My message is that I'm lucky enough that in Italy I have easier cases than this, first. Second, now apart from kidneys, this is a very, very tough case that is supposed to require at least 3 tracts, I would say. So my suggestion in this case is to do the 3 punches in the beginning, then dilate only if you're gonna need along the way. I would start with a puncture in the lower calyx, in the middle one, guide wire down in the ureter, and one in the upper calyx going in this direction. And then I will start with the first. Usually I start from the calyx where the majority of the stone is. So my first dilation would be in the upper calyx. Remember, this is an advantage maybe of supine PCNL for upper pole puncture, because when the kidney is so high, in prone, you do the puncture much more posterior, so you have more problem of interposition of the liver. Instead, in supine, going from the flank, usually you can have more room to stay behind the liver just to reach the upper calyx. This is another little advantage. Then, of course, always ready to do combined, but I think that the complexity of this stone for sure is going to require at least three accesses, maybe 124 in the upper calyx and 2 mini-perc in the other two accesses.
All right. I think you have elaborated how to make the puncture, especially for the supracostal and the above the 12.3, because that is the fear in everybody's mind. I think you have made your point. And just to tell you how we did it is that first we cleared up the left side. It was quite straightforward. In the prone position, of course, left side was cleared. And in multiple position, multiple stage and multiple tracks, this was the first, second, third stage. We cleared up the whole stone completely, requiring multiple tracks. So that is how we did case. And then 4 years follow-up, completely stone cleared, and we proved that yes, the function was properly maintained. Well, coming to the last case, before we take up the questions from the audience, yes, you want to say something, Dr. Gusti?
Yeah, that's an important point, that even such a complex PCNL with multiple accesses, if you do the accesses correctly, respecting the anatomy of the kidney, the functional result is always very, very good. And for sure,
yes, absolutely.
If you are expert, of course, it is much more respectful for renal parenchyma, a multi-access PCNL, rather than a 5 stages flexible ureteroscopy of 2 hours each.
Absolutely. Now, coming to our last case, I want your input. This is a patient who has undergone the left pylorith 10 years back. You see that the 12th rib is cut. The 12th rib was cut, and this is the stone which he has found. Now, if you see the IVP, he has got the calysis. Obviously, the whole position is completely different because it's a post-pylorithectomy, completely different angulation. And you can see here that this is a dilated calyx. This is one outpouching. This is one outpouching. This is one outpouching, and this is the narrow infundibulum leading to pelvis. Now, how would you approach this case? You think this case is good for supine, or this case would be better for prone, especially when you have a previously operated case?
Listen, now I will surprise you a little bit. Previous operated patient is, I would say, an advantage in supine, because the scar usually stabilizes the kidney and you have less hypermobility when compared to normal patients. So the fact that the patient has already undergone a previous open surgery is not a big deal. This is for sure a good case for supine, and I would say for edges, because you know this stone is very, very branched, so it's impossible to clear only percutaneously. And I think that a good cooperation between two surgeons, one ureteroscopically, one nephroscopically, it can do a good job. That being said, is definitely a very, very difficult cases because you have multiple stones everywhere. But of course, maybe it will require 2 stages, but I would go for edges in supine position.
Right. So I think you have made lots of points, and there are many, many questions which have come up. Obviously, we can't take all the questions. Some of the questions, yes, sir.
I wanted to ask Dr. Gisto, what size nephroscopy you will use? What size Amplas sheet? How much you will dilate? Would you prefer? What is his opinion about mini perc in supine position?
Honestly, you know that I'm a little bit famous for a paper mini perk. No, thank you. But don't worry that the paper mini perk, yes, please, is on the way. I changed completely my mind. Mini perk with the last generation scopes is a wonderful weapon that we have in our hands. And for sure, in this case, I would go for mini perk 16 point up from car stores. So this is my favorite way of doing mini perk, because don't forget that we have many stones, but the bulk of the stone is not so big. So I would spare a big access to this kidney, but mini perk would be a good option for me. But another point that from my point of view should be stressed is that honestly, the feeling that I have when I go in the OR is that the best kind of surgery that you can offer the patient, you can realize only when you are in the OR. So usually I ask my patient to write an informed consent in which they allows me to do almost everything, because sometimes you think that mini perk is okay, then you go inside, the stone is bigger, or even, this is another advantage of supine, all my stone bigger than 1 centimeter, when they are scheduled for flexible, they also allow me to shift to supine, because as soon as I have the feeling that I'm not doing a good job ureteroscopically, I change, the patient is already in position, and I will go for perk. So this is important. We have to be flexible, not only with our scope, but also with our indications. And the final indication is always in the OR, at least in my experience.
All
MRD,
right. So coming to the question, Aditya, I'll come to you
yeah.
because I want to ask you also the questions. First, the question to Guido, when you showed in your demonstration that you move the C-arm to cranial and caudal. Now, do you move C-arm how we do in a prone position on the side to side, or it is always cranial and caudal? Because what the question which is asked is that if you make really a cranial and caudal, then when you make too much of a cranial, the heart is going to get a lot of radiation. Now, is that the fear in your mind?
But honestly, I only tilt the C-arm cranial. You can do also, let's say, a kind of bullseye technique in the other way, also in supine, but it is much more demanding. And what is the problem is that you have to keep the C-arm on the side of the surgeon, which is a little bit disturbing. But believe me, at least in my experience, since the puncture is much easier, radiations are not a problem, because usually the puncture is very, very fast. And if I am in trouble, I also take a look with my ultrasound. So I use only cranial, but if you want, you can use also in the other way, but it is much more demanding.
Okay, now Aditya, the question to you is that if you see all the people who are doing prone PCNL, a majority of them have learned prone PCNL with a bullseye technique, which is supposed to be much scientific and much easy, very, very easy to learn. Now, the main hindrance of supine PCNL is you can't do bullseye technique. First and foremost, is it correct that you can't do bullseye technique? And if it is not a bullseye technique, how difficult and easy it is to learn puncture in supine position?
Yeah, sir, I totally agree that bullseye is a easier method and more replicable method, but it is not in line with the direction of the calyces. So anatomically, bullseye may not be very friendly if we want to access entire kidney through one puncture. Having said that, triangulation is slightly difficult to learn in initial cases, but after I can say 15-20 cases, uh, so far I have never had any problem of puncture, and overall radiation is less than 30 seconds for almost all the punctures.
All right. Now, Guido, do you have the experience of doing supine PCNL in the pediatric patients? Does it pose any more additional problems and difficulties?
Well, unfortunately, I don't have experience with pediatric patient, but there is a friend of mine close to Milano, and he has adopted supine PCNL and with the same advantages than in the adult population. But honestly, I don't have
Right. Now,
We have done 10 cases.
yeah, Aditya, you do PCNL in the
Yes,
supine
sir.
in the pediatric? All right.
Yeah,
Okay.
we have done 10 cases.
Now I want to pose to Dr. Gudo that when you do supine PCNL, you always tell the advantages that you can put a flexible ureteroscope, and you also showed in your talk that so many cases you put past the ball and is that. Now, is it that you are running away from supine PCNL by taking the advantages of flexible ureteroscopy, and you're highlighting that your supine is better because you always have the flexible ureteroscopy with you, whereas in prone, when we do PCNL, everything we clear up with PCNL, whether it is one puncture, two punctures, push or whatever. Now, is it that it is the you are banging on the success of supine PCNL on the RIRS?
I would say no. I would say no. For me, at the end of the day, the procedure is the same. So I wouldn't say that if you don't have flexible instrumentation, it's better to go for prone. And this is an important point because this was a little bit, let's say, fault of my friend Cesare Scafone, that he was so successful in pushing edges that actually most of the people, they think that if you do supine, it should be edges. It's not true. In my experience, edges is needed in only 30 to 40%. But don't forget that supine PCNL is very, very effective also without flexible manipulation. For example, in mini-perc, this is the concept. I am always ready to do combine, but I do combine only if it is needed.
Right. Dr. Mahesh Desai, sir, you want to ask a question to Guido?
No, yes, I agree with Guido regarding the use of flexible ureteroscope because, as you know, we were doing the prone PCNL for many years, and multiple puncture was our specialty in clearing the stone. But problem was that it always had a more bleeding, and to reduce the bleeding, we reduce the number of tract and use the flexible ureteroscope. So if you in supine position, you have a one PCN, and as Abhishek shown, use the flexible and do this thing would be better. So I mean the flexible ureteroscope nowadays to clearing the stone, the single puncture with flexible ureteroscopy, even in prone or supine, is an ideal thing. So my question is to Guido is that I just read one paper where they had done compared the prone to supine position, and they had shown many advantages of supine position, but one factor was that prone position clears the stone much more than the supine position. Now that statement, do you agree with that statement?
Not at all. Is it enough? No, I don't. It depends. For me, the surgery is just the same, and I can answer you back. Do you think that if I had the feeling not to serve my patient in the best way, I will be here to support supine? For sure, no. But I'm quite sure that it's a matter of mentality. Believe me. Also, before 2006, I was also skeptical about supine because my mindset was just focused on prone. But at the end, believe me, you can do the same job. I don't want to tell you that it's better. It's the same procedure, only the way to get the access is different. But I can only tell you these are the things. I don't know one single experienced endourologist that after switching to supine went back to prone. What does it mean? That is effective.
Yes. Judo, there are a lot of people who have asked that you have the large experience of supine PCNL almost in every case. What is your experience of injuring the liver and the spleen? Because that's a fear in people's mind. Those who wish to do supine PCNL, these are all fears. Why I'm asking you these questions, because these are all hindrance of supine, and I want answer from you.
Honestly, the chance to have a problem is more or less similar. I would say a little bit less in supine. Honestly, I went 3 times already through the liver, 1 in prone and 2 in supine, and nothing has happened. And so far, I'm touching wood, no case of splenic injuries. But as far as I know, splenic injury is much more risky, is much riskier than the liver one, because when you have a problem with the spleen, the likelihood of performing a splenectomy is very, very high. But with the liver, of course, you have to do your best not to damage the liver. But in my 3 cases, nothing has happened. 1 was mini-perk and 2 were 24 French access.
Right, Aditya. Now you said that your primary choice or almost all cases are in supine position. Now tell me that after doing so many cases in supine and for such a long time, do you have any selection criteria, or any case is for supine PCNL if he is for PCNL?
So, I would like to start my answer with a statement that whether we do supine or prone, it is like whether you are driving on the left side of the road or the right side of the road. Once you are in the system, it really makes no difference whether you have started it on supine or prone. So, because I've been doing supine for very long, so technically it never comes to my mind.
Right, correct. So I think that's a very bold statement, and that's a very clear statement for all of us. And before we end the session, I want answer from Guido, because there are so many people who are watching. Tell me, what are the disadvantages of supine PCNL?
You've already told.
Well, I told you during my lecture, the most important thing to be aware of is the hypermobility of the kidney. When the first time that you experience hypermobility of the kidney can be very scary, because by pushing with the needle or with the Alkenset, you will push the kidney on the other side of the patient. So in this case, it's very important not to exaggerate, because some colleagues had a very big problem, especially on the right side, where the vein is short, and this movement of the kidney can be very risky to give a lot of tension on the pedicle. So this is the only thing to be aware of, because it can be very, very dangerous.
Rest, in every case, you will definitely go for supine PCNL, right?
I can only tell you this: 6 months ago, I had to go back to prone for a hypersplenomegalia. There was no window for supine.
Okay.
And you know what? Was funny? That in my OR, nobody had seen a prone PCNL. So my team, that usually is the best of the best,
that's a problem.
Yeah, they were horrible in assisting me, because nobody knew what to do.
Correct. Actually, I was going to ask you that in case of a trouble, if you have no experience of prone, do you find it difficult to go in prone rather than supine? So that was anyway. I think this was a wonderful session. And before I ask Dr. Desai's remarks, I must say that you and Aditya both have contaminated a lot of people, and I'm sure the spreading of PCNL would be faster than what Corona is spreading in our country. So far, the spread was a bit restricted, but I'm sure a lot of people who are watching this, they are likely to get convinced, and the supine PCNL will spread with a much faster rate, and that is what Aditya has been trying for quite a long time. And before we conclude the session, I want Dr. Mahesh Desai to offer the concluding remarks. Thank you very much.
Well, thank you, Sabnis, for conducting this beautifully and bringing out a very technical and important point. I've been in PCNL since 1985, and I've done everything: prone, supine, oblique, local, um, and we have now treated more than 40,000 stone treatment. Out of that, 16,000 is a PCNL. What is my feeling at the moment is we must learn everything. We must learn supine, we must learn prone, we must learn in every situation, because patient offers, like, what we have seen, a osteogenesis imperfecta, or there may be a kyphoscoliosis, or there may be a pregnancy, or there may be where you may have to tailor your approach according to the patient. You should not be only technique and then use that for every patient. I think most important is a supine position is a good alternative to the prone position, but one must learn both, because in any situation you should be able to do it. And supine position does require a different kind of orientation, and the student must be aware of this orientation. And I feel the supine position is anesthetic friendly, the position wise is very good, and you can have clearance as good as the prone position. I have no doubt with availability of this combined procedure, you can have any stone which is treated. But as a student of endourology, you must learn everything, and that is the thing. And I think, Dr. Gisto, I'm so much grateful to you for bringing out such a minute detail, because we were not really, people were not aware of the position, where to give a puncture, what angle should be there, what are the position. You have beautifully explained everything, and I'm also helpful. Abhishek, you have also shown the combined procedure to be a very effective. Aditya, you have also brought out many things. I just came to know today only that you are only doing supine PCNL. If you want to learn prone position, I will teach you also. So that is okay.
So before we hang up, I want Aditya to say a few words, and then last word from our Professor Gusti. So Aditya, you want to say something?
Sir, this has been a very amazing opportunity to share space with legends of urology. When before PCNL started, kind of supine started in '87, and Sir said he has started PCNL much before that, and his appreciation means a lot to me. And I would really like to come and work with you, sir, sometime if you give me the opportunity. I'm really thankful for this opportunity. And supine is the way to go. Supine is future. Thank you.
Well, Guido, you have the last word, and then we hang up.
So I can only say thank you very much for this invitation. So after Brexit, this is time for prone exit, okay?
Right.
Okay, thank you very much. And
So
don't forget
that
I think to be reliable, because before shifting, I perform already 1,000 prone PCNL. So I do know what I'm talking about, and I did appreciate the advantages. Thank you very much to be let me be part of this wonderful event. Ciao, ciao.
Bye bye.
Thank you.
Thank you.
Bye bye. Bye bye.
Thank you.